Before delirium can be managed or prevented, it is important to understand what it is and why it is so important for nurses to be educated on it. Medline Plus defines delirium as sudden severe confusion due to rapid changes in brain function that occur with physical or mental illness. It is a serious health condition that is commonly seen in older adults. Delirium contributes to prolonged hospital stays, poor patient outcomes, increased rates of mortality, and ongoing cognitive impairments. Recognizing delirium can be difficult in clinical settings due to many factors. Due to the fluctuating nature of delirium, it is difficult to understand the significance of the problem. Prevalence rates can range anywhere from 10% to 80% in the literature. While delirium can occur in any patient and in any care setting, the highest prevalence appears to occur in the critically ill requiring mechanical ventilation. It is important for clinicians to be skilled in detecting delirium in order to protect our patients by intervening early, treating appropriately, and preventing negative outcomes. Delirium is often confused with dementia. While both are impairments of cognition, it is imperative to understand the key differences in the two conditions. First, delirium is an acute change in cognition with a sudden onset of symptoms. Dementia, on the other hand, is a gradual change in memory and awareness. With delirium, initial symptoms vary with the type and severity of delirium experience and is often behavioral in nature. Dementia presents early on with deficits in memory and recall, and behavioral changes usually aren't present. Finally, delirium is temporary and can be resolved in as little as a few hours. It can also take weeks to months for all symptoms of delirium to resolve. Dementia is an irreversible condition that progressively declines. The most important distinction between delirium and dementia is the potentially reversible feature of delirium. There are 3 types of delirium, and they are distinguished based on symptoms. Hyperactive delirium is the most recognized form of delirium and presents with agitation, incoherent speech, disorganized thoughts, delusions, hallucinations, and/or disorientation. Manifestations of this form include agitation, pulling an IV or catheter tubing, restlessness, climbing out of bed, attempting to elope, and/or physical or verbal aggression. On the other end of the spectrum is hypoactive delirium. Symptoms consist with hypoactive delirium include sluggishness, drowsiness, decreased reaction time, withdrawn or sullen appearance. Hypoactive may mimic coma or stupor and is the most common form of delirium. Because their behaviors are not as problematic, patients with this form of delirium are largely under-evaluated. The third type is mixed state delirium, and is what the name implies, a combination of both hyperactive and hypoactive. It is common for patients with mixed delirium to experience daytime somnolence and insomnia or nighttime agitation. Now that we know the types and symptoms of delirium, as well as the difference between that and dementia, it is important to be knowledgeable about the causes of delirium. While the exact cause of delirium is unknown, there are many contributing factors to its occurrence in older adults. Delirium is rarely a result of one issue. However, there are both predisposing and precipitating factors that contribute to delirium. Predisposing factors are underlying conditions that contribute to a patient's overall vulnerability. These conditions include, but are not limited to, the following: advanced cancer, cognitive impairment, polypharmacy, chronic pain, dehydration, fluid or electrolyte imbalances, metabolic disturbances, hypoxia, impaired cardiac or respiratory system, infections such as UTIs or pneumonia, malnutrition, multiple comorbidities, sensory impairments such as loss of vision or hearing, or an unfamiliar environment. Precipitating factors are events or triggers that occur during the hospitalization that can lead to delirium. These triggers include absences of clocks and watches, absence of reading glasses or hearing aids, acute cardiac or pulmonary conditions, immobility or bed rest, drug withdrawal, fecal impaction or urinary retention, fluid or electrolyte disturbances, frequent room changes, indwelling devices such as catheters, medications, nosocomial infections, restraints, severe anemia, sleep deprivation, and uncontrolled pain. There are many instruments to detect delirium. While each tool has its advantages and disadvantages, the nursing assessment is a critical step in recognizing and treating delirium. Perhaps the most crucial part of a nursing assessment is the mental status examination. This assessment includes a general focus on cognitive functioning, attention, orientation, language, memory, and reasoning. Breaking this down further classifies the assessment method. Attention refers to a patient's ability to maintain focus and engage appropriately. Orientation involves awareness to person, place, and time. Language consists of the ability to communicate. Memory is a bit more complicated in that it considers primary, secondary, and tertiary memory. Primary memory is the working memory and is the ability to recognize information. Secondary memory evaluates recall. Tertiary memory assesses the recall of facts learned long ago. Assessment of reasoning appraises patients' abstract concept formation. The clock drawing test is the most effective measure of reasoning and is the most valuable tool in evaluating improvement in delirium. The clock drawing test is administered to patients to determine their cognitive status. The instructions are given as follows. Draw the face of a clock. Place the numbers on the clock and put the hands at 10 minutes past 11 o'clock. This simple test reveals significant information, including planning, which refers to the size of the circle drawn, organizing, which would be the placement of numbers inside the circle, sequencing, which includes the numbers in sequential order, and abstraction, length and placement of the hour and minute hand. Pictured here is a CDT during and after an episode of delirium. Here is a chart that compares the different delirium assessment tools used in clinical settings. There are advantages and disadvantages to each as outlined above. Currently, the most utilized tool is the confusion assessment method. This evidence-based tool comes in a long and short form style. The short CAM is quick and accurate with only 4 items to score and is well known to nurses in many different fields. Disadvantages to this tool include a varying degree of sensitivity based on experience and training with the clinician or nurse implementing the assessment. We will review a study performed to relate infection and severity of delirium. In that study, the Memorial Delirium Assessment Scale was used. The MDAS is a 10-item scale that requires an hourly measurement of delirium and rates the severity of delirium. It does take longer to complete at an average of 10 minutes. What you see here are questions found in the CAM long form. There are 11 questions and delirium is scored based on the presence of these features. A higher score indicates higher severity of delirium. This slide contains the questions or features found in the CAM short version. The short version is based on the first 4 of 11 questions from the long form, as outlined on the previous slide. Its clinical usefulness has been validated in several studies. Feature 1 involves the patient's baseline, acute change in mental status, and any fluctuation in presence and/or severity. Feature 2 considers inattention, distractibility, difficulty with conversation. Feature 3 covers disorganized or incoherent thoughts or conversations. Feature 4 requires assessment of the level of consciousness. In order to diagnose delirium using this tool, the patient requires the presence of both features 1 and 2 along with either feature 3 or 4. The course of treatment for delirium is largely dependent on the underlying cause or trigger. Because of this, the first goal of treatment should always be to identify and treat the underlying cause. Some examples include discontinuing certain medications, addressing metabolic imbalances, treating infections, and controlling pain. Once the cause has been identified and is being treated, the primary objective should shift to creating a healing environment. This can be accomplished by encouraging family involvement, providing reassurance, and always explaining what is happening. avoiding unnecessary sleep interruptions, removing unnecessary invasive devices, bringing familiar objects from home, noise reduction and decreasing stimuli, and avoiding the use of restraints. The most current recommendations advise against using sedating medications and antipsychotics unless the patient is experiencing acute agitation, their behaviors are disrupting necessary care, or they are presenting a danger to themselves or others. There are several medications that are commonly used to treat the symptoms of delirium, one of which being Haldol, which is generally the agent of choice for the treatment of acute delirium. Additional medications include Zyprexa, Seroquel, and Risperidone. While these medications are being used, the patient should be monitored closely for extrapyramidal effects and prolonged QT intervals. It is also important to note that the use of these medications have been associated with an increased mortality rate in older patients with dementia-related psychosis. The use of benzodiazepines, such as lorazepam, should be limited to treat delirium associated with alcohol or benzodiazepine withdrawal. The use of benzodiazepines may in fact worsen delirium. In 2016, a study was done following 60 patients at Sanglah Hospital's geriatric inpatient ward, almost equal men and women. They all had delirium, which is defined by the Memorial Delirium Assessment Scale, or MDAS. Infection was confirmed by lab tests, x-rays, and clinical findings. Cascade of changes in the central nervous system. Systemic inflammation caused by infections like urinary tract infections cause a spectrum of changes manifested as delirium. These changes may be described as conserved behavioral and metabolic responses to infection, affected to conserve energy and minimize the spread of infection. The study results indicated that there were no significant severity of delirium between males and females. Patients with sepsis had a significantly higher MDAS score than those without sepsis. Surprisingly, BUN had no effect on the severity of delirium. Frequency of mild delirium is higher than moderate or severe. Looking at these percentages, you can see that the rates of delirium increase significantly with patients who have a documented UTI infection. The percentage more than triples in these cases. There are certain actions that can be taken in the prevention and treatment of systemic infections. These include avoiding the use of long-term indwelling catheters. Antibiotics should be taken at a prescribed time in the proper dose, starting with a narrow-spectrum antibiotic. Genital hygiene should be carefully monitored. Should encourage ambulation. Probiotics and cranberry juice. Avoid bladder irritants such as caffeine and alcohol. Monitor temperatures and lab results carefully, and check adult diapers every 2 hours. When looking at modifiable risk factors for the prevention of delirium, several interventions should be considered, including sleep promotion, increasing familiarity, and frequent orientation. Clustering care is helpful during night shift, especially in limiting disturbances to patients' sleep cycle. Obtaining vital signs, addressing patients' restroom needs, and medication administration should be clustered as much as possible to promote a good night's sleep. Adequate lighting is needed to promote safety in the room, but adequate lighting is also needed to promote a sleeping environment. Overhead lights tend to be bright and fills the whole room with the necessary light needed to ambulate around the room. However, lights located on the walls of the patient's room tend to be less illuminating, especially when the light is located on the lower half of the wall. The light radiates outward instead of down on the patient. Brushing teeth, bathing, changing gowns or clothing, and applying lotion can be utilized as a nighttime routine for a patient. Ask a patient, What do they do before they go to bed at home, and help incorporate this into their plan of care in order to promote a sleeping environment. If a patient is able, help them ambulate multiple times during the day. This can increase awareness in their environment by ambulating in the hallways and help them exercise. Encourage family members and friends to bring in items from home to increase familiarity in their room. Cards, blankets, trinkets, and books give something for a patient to do and look at. Also, these items can help orient the patient to their surroundings and of their loved ones. Utilize windows in the patient's rooms. Opening the shades or curtains every morning helps the patient to realize the time of day. With that being said, allowing the patient to see the sun go down before closing the curtains may orient a patient into realizing that it is time to go to bed. Utilizing clocks and calendars as a reference guide for patients can help increase independence and orientation. Be sure to update each patient on their plan of care throughout the day. Allowing the patient to know the purpose of each intervention and why they are still in the hospital can help to empower and promote awareness of their care. Communication boards can be used to write the names of their care team, the date, test, procedures that are planned for the day, and their location. The patient may refer to this board during the course of their visit as an orientation tool. In conclusion, nurses play a critical role in recognizing, treating, and preventing delirium. It is important to be aware of the different types and subtypes of delirium, appropriate treatment plans, and causes and modifiable risk factors associated with this medical emergency.